family nurse practitioner, and I'll be responsible for performing your pre-procedure assessment this morning. Okay, so I have a couple of questions for you first.
All right.
The primary evaluation for the patient can occur anywhere from a week to a couple of days prior to the procedure, but the standards require, and it's very good practice, to reevaluate the patient immediately before the procedure to make sure there's been no change in the patient's status in the interval.
This health assessment involves reviewing the patient's history and physical, including the indication for the procedure, important medical conditions, especially cardiopulmonary status, allergies or adverse drug reactions, prior sedative or anesthesia experiences, and potential for pregnancy. The evaluation also involves a physical assessment of the patient that includes baseline vital signs including oxygen saturation and weight. The evaluation assesses other items as well. These areas are the airway status of the patient's aspiration risk factors, the appropriate fasting interval for the elective case, at least 6 hours, and the patient's cardiac and pulmonary status. 3 other things need to be assessed as well, including the patient's general neurologic status, mental status, and level of consciousness. The patient assessment process culminates in assigning an ASA physical status on a scale of 1 to 5. Each number on this scale categorizes the patient according to his or her condition. A score of 1 indicates that the patient is healthy, while a score of 2 indicates that the patient suffers from a moderate disease, but is stable and the disease is not of a nature that would limit the lifestyle of the patient. A score of 3 designates that the patient is suffering from a severe disease, one that will limit his or her lifestyle, but the patient is still considered stable. A score of 4 on this scale indicates that the patient is suffering from a severe disease and is unstable, and a score of 5 is used to designate moribund patients.
If the evaluation uncovers a potentially problematical area, it's important to consult with the appropriate specialist to resolve the problems. That could be a pulmonologist, a cardiologist, or an anesthesiologist. Another element of the risk assessment is to determine if the patient's airway might be difficult to manage during the procedure. Certain things in the patient's history indicate a potentially difficult airway. They include a history of snoring or stridor, sleep apnea, a history of having had a tumor in the airway with or without radiation therapy, trauma to the airway, a tracheostomy or airway surgery.
Certain physical characteristics of the patient can indicate an increased possibility that the patient's airway could be difficult to manage, including a short, fat neck with limited neck motion, especially extension, a limited mouth opening, an overbite or receding mandible, TMJ disease, arthritis, carious, loose, or prominent teeth, a large tongue, and the patient's Mallampati classification.
The Mallampati airway classification is designed to risk assess the airway from the standpoint of the ability to maintain a spontaneous airway. A Class 1 airway is a normal airway and allows you to see the hypopharyngeal structures by when the patient is asked to open his mouth. You can see clearly the posterior pharynx. Class 2 airway shows some obstruction with the tongue and soft tissues obstructing, and 3 and 4 show limited or no visibility of the posterior pharyngeal structures, and that suggests an airway that's at risk. Risk assessment of the airway also includes the collateral risk of aspiration of gastric contents into the airway when the patient's protective reflexes are depressed by sedation.
The evaluation also assesses the patient's risk of aspiration during the procedure. Many factors indicate an increased risk of aspiration, including an anticipated difficult airway from factors just discussed. Also, abnormal GI anatomy, including a swallowing disorder, hiatus hernia, and GERD. Other factors include obesity, pregnancy, diabetes with autonomic dysfunction, mental incompetence, and either increased intracranial pressure or decreased level of consciousness.
We're just going to discuss Samantha's preparation tomorrow for her surgical procedure. She can have nothing by mouth, no fluids, no food by mouth after midnight tonight.
This evaluation also provides an opportunity to educate the patient, or in the case of children, the child's parent, on the fasting protocol that should be adhered to for the patient's safety. These fasting protocols differ from adults to children, and remember, these recommendations are conservative. Adults should refrain from solid food and milk after midnight the night before the procedure is to be performed. However, clear fluids are permitted, but only up to 4 hours prior to the procedure. Preoperatively, medications may be taken, but with only a sip of water. The fasting protocol for children depends on the child's age. Children 3 years and older should refrain from food or milk 8 hours prior to the procedure, while children aged from 6 months to 3 years should refrain from food or milk 6 hours prior to the procedure. Infants under 6 months of age should not be given formula for 4 hours prior to the procedure. All children may continue to drink clear fluids after they begin the fasting protocol, but only up to 4 hours prior to the procedure. The evaluation includes laboratory tests as needed to guide therapy, assessment of the need for blood or blood products for transfusion in rare instances, the determination that the patient is a suitable candidate for the planned procedure and sedation, patient education regarding risk benefits and alternatives, obtaining informed consent for the procedure with sedation.
Okay, we're going to have you sign the operative invasive diagnostic procedures requiring anesthesia or sedation consent. Okay. So.
The pre-procedure assessment culminates in a plan of sedation and a plan of nursing care. The patient must be re-evaluated for suitability just before starting the sedation. Arrangements for a responsible adult escort for adults and children undergoing outpatient procedures should also be made.
The sedation plan involves the choice of the agents to be used and knowledge of the duration of the procedure and any complexities it may bring, and also a plan of nursing care for the patient both before, during, and after the sedation.